Guten Abend, liebe Allergologie-Fans und ganz herzlich willkommen zu einer neuen Ausgabe von Faszination Allergologie. Dieses Webinar ist unsere 20. Ausgabe und das haben wir heute zu feiern und dazu haben wir einen ganz besonderen Gast eingeladen. Doch dazu mehr nachher in der Sendung. Was sich in den 20 Ausgaben bisher nicht geändert hat, ist, dass ich Sie auch heute wieder als Gastgeber und kreativer Kopf dieses Formats begrüßen darf. Und falls Sie heute das erste Mal dabei sind und unser Projekt vielleicht noch nicht kennen, so schauen Sie doch einmal vorbei unter www.faszination-allergologie.de. Dort erhalten Sie zahlreiche Informationen rund um die Allergologie, die Aufzeichnung aller bisherigen Webinare sowie nützliche Karrieretipps unserer Experten. Außerdem können Sie sich für unseren Faszination Allergologie Newsletter anmelden und verpassen auch keines unserer Webinare mehr mit unserem Erinnerungsservice. Nun lassen Sie uns einen kurzen Blick auf die Agenda des heutigen Abends werfen. Nach einem inspirierenden Vortrag von unserem heutigen Gast, Professor Sharon Chinthrajah, über Nahrungsmittelallergien wird sie einen Case Report vorstellen, bei dem Sie wieder mitraten können und Ihr Wissen unter Beweis stellen können. Zum Abschluss des Webinars möchten wir Sie dann noch einladen zu einer lebendigen Diskussionsrunde mit Professor Chinthrajah und unserem Moderatorenteam. Und wenn Sie schon immer einmal wissen wollten, wie zum Beispiel die allergologische Landschaft in den USA ausschaut oder wie Sie vielleicht dort Ihre Karriere starten können, dann löchern Sie unseren heutigen Gast einmal richtig kräftig mit Fragen. Und auch heute habe ich wieder eine gute Nachricht für alle Punktesammler, denn auch dieses Webinar ist wieder mit 2 CME-Punkten zertifiziert, sodass das noch attraktiver ist für alle, die CME-Punkte brauchen. Und wir setzen uns auch dafür ein, dass alle zukünftigen Webinare CME zertifiziert sind. Wichtig ist dabei aber, dass Sie bis zum Schluss dranbleiben. Und wie immer nach unseren Webinaren erwartet Sie eine kleine Evaluation. Wir würden uns total freuen, wenn Sie sich 1 Minute Zeit nehmen und einfach uns Ihre Meinung sagen. Was hat Ihnen gefallen? Was hat Ihnen vielleicht nicht gefallen? Und was wünschen Sie sich für die Zukunft? Und für die Teilnehmer, die unser Format noch nicht kennen, hier noch eine ganz kleine Information, wie Sie mit uns kommunizieren können. Und zwar, indem Sie uns Ihre Fragen in die FAQs schreiben. Falls das kleine Panel FAQ bei Ihnen noch nicht sichtbar ist, so klicken Sie einmal hier unten auf dieses Symbol Chat und dann sollte das entsprechend wieder aufploppen und Sie können Ihre Frage dann an uns und unseren Gast stellen. Das Besondere heute ist, dass wir einmal sozusagen den Lebenslauf, den wir sonst immer vorstellen, überspringen. Diesen, verspreche ich Ihnen aber, binde ich dann in die On-Demand-Version unserer Aufnahme ein und den können Sie dann in etwa 4 Wochen noch einmal in Ruhe anschauen. Und damit begrüßen wir nun den Gast unseres heutigen Jubiläums-Webinars, Professor Sharon Chinthrajah. Welcome to our show. And I also welcome our moderators, Professor Treidel-Hoffmann, Dr. Julia Kurz, and Sebastian Seurich. Welcome.
Welcome, Sharon. It's so great to have you here today. And yeah, it's extra special for us because you are our first expert from the US. And usually in our show, we start with one question for the expert. What fascinates you most about allergology? Can you maybe put this into short words?
Well, first of all, thank you so much for inviting me and having me. I am so honored and so excited to be here. What fascinates me about allergy is that it is a field that we are learning about every single day. It touches every aspect, every organ in our system with immunology and is relevant to everything in our everyday life. When a pandemic like COVID comes along, it's relevant. When when you hear your grandmother's tales of, why you shouldn't go to sleep with cold, wet hair, there is a little bit of immunology in there somewhere, So I think that it's really exciting to try and find the science behind all of these stories that are passed down to us.
It's so nice to see others get that involved and to see them so excited about allergology as well. And we're so happy to have you. We are excited to have you give a presentation about oral immunotherapy in the US today. And we're very much looking forward, as many things are very different from Europe, and the stage is yours.
Thank you so much. So I'm excited to talk about food allergy and oral immunotherapy and what the future holds for this large population of people that suffer from food allergy. These are my disclosures. So oral immunotherapy involves taking these small cups of food that the patient is allergic to and starting with homeopathic doses in a medical setting, exposing them to very tiny dusts of the food, and then increasing the amount of food that's consumed on a daily basis over time. And that process is desensitization. And it's similar to drug desensitization or aeroallergen desensitization to pollens in the air for seasonal allergies. And this is for food through the oral route, which will be the main focus of my talk. There's also active investigation for epicutaneous immunotherapy and biologics targeting the allergic inflammatory cascade, which I'll talk a little bit about. So food allergy oral immunotherapy started in 2008 in the first randomized controlled study, so over a decade. It's a long process. It can take 3 to 5 years to be desensitized to one food, depending on how much food that individual wants to consume at the end of the day. It has many side effects, including anaphylaxis, which we're all concerned about, and more commonly abdominal pain. And sometimes this is the reason that patients stop doing oral immunotherapy. Very exciting is that the first drug for peanut allergic children was approved in the US and in Europe. And I understand that Germany is also working hard on it, I believe, with Palforzia. And what we found at Stanford is that many people were coming to us allergic to foods beyond peanut. 70% of food allergic individuals that we were seeing had multiple food allergies. And we thought about adding biologics like an anti-IgE or an anti-IL-4/13 to oral immunotherapy, or even higher in the cascade with alarmins, anti-alarmins like anti-IL-33. And so we've performed over 35 studies across all the ages, babies to adults, and I'm excited to share some of that data with you today. So this New England Journal article from now many years ago, looking at the Palisade study, looked at peanut oral immunotherapy and compared peanut to placebo oral immunotherapy, where peanut allergic children built up to 300 milligrams of peanut. That's roughly one peanut, and then maintained one peanut daily for 6 months. And at the end of that year, 50% could consume 3 peanuts. So just taking 1 peanut a day increased their threshold 3-fold after 1 year. But we saw in this study, this first phase 3 study, that side effects were common. And the most common were GI side effects, and this led to dropouts. So the question is what do they have to take peanut for the rest of their lives? Is it similar to allergen immunotherapy for pollens, where you do a buildup over 1 year and then do maintenance for 3 to 5 years? And that's what we did for the POISE study. We really tried to understand not only desensitization, but long-term dosing options and sustained unresponsiveness. There's many words for this, sustained unresponsiveness or tolerance. My patients think of it in the mindset of a cure for their peanut allergy. But as immunologists, we're hesitant to say that because we need to test it. And that's what we were trying to do in the POISE study. So we took 120 peanut allergic children and adults. At baseline, they were allergic to 25 milligrams of peanut protein. That's about 1/10 of a peanut. And we built them up to 4 grams of peanut or placebo over the course of the first year. That's about a tablespoon of peanut butter. I don't know in Germany if you guys like peanut butter as much as the Americans, but this is a staple in the American diet. And then in the second year, they maintained 4 grams of peanut or placebo. And then the third year is really when we were testing the long-term outcomes. So patients had been randomized into placebo, which they continued, dropping down to 1 peanut a day in the third year, or going on to avoidance. And everybody got food flowers, so we don't know who was who, and neither did they. And this was work that was done with my colleagues, Dr. Kari Nadeau, Dr. Stephen Galley, Dr. Scott Boyd. Not only were we doing the clinical trial, but we were also looking at the immune cells throughout this journey of desensitization and long-term outcomes with basophils, T cells response, and B cell responses. And what we saw is that you can build up to 4 grams of peanut protein. And then when you reduce the dose or continue avoidance, only very few people are actually able to maintain non-reactive sensitivity to 4 grams of peanut upon repeat food challenge. So in that third year, we did food challenges every 3 months. And those patients who were able to pass 4 grams of peanut protein were allowed to continue. And here I'm showing you the people in blue are the ones that maintained 1 peanut a day. And you can see that more of those people compared to the gold who went on to avoidance were able to have that high threshold sensitivity. The important point to note also, and gray is placebo here. So there was one individual who had outgrown their peanut allergy in the course of this 3-year study. And here, and this is in the Lancet, so you can take a longer look at this, but important to note is that we set the bar of pass-fail pretty high, 4 grams of peanut protein. But these patients still were able to maintain some level of desensitization, which is really important from the patient perspective. And that's what I'll show you here. 13% of patients who avoided peanut in the third year could still ingest 4 grams of peanut. So those are truly the individuals who had sustained unresponsiveness and more likely mimic what we think of as a peanut cure. But 95% who continued with 1 peanut a day were able to tolerate more at subsequent food challenges than when they had originally started. So not all is lost, and that it is probably a decay curve. And we really need better biomarkers to be able to understand who is going to fall into the 13% group and who's going to need a peanut a day to maintain some safety from accidental ingestion. As I mentioned, we did blood work every 3 months for these wonderful research participants, and they were amazing because it takes these families a lot of work to be able to contribute to science and research and move the field forward. So we're so grateful. And we looked at basophil reactivity and peanut-specific IgE. And what we noted is actually, here I'm showing you basophil activation. Those patients who lost reactivity after the first 3-month change in their peanut regimen, when they, at week 117, 3 months into the third year, are in red, and the successful ones are in blue. And you can see that the successful patients have lower basophil reactivity at baseline and throughout the study. And you can see when patients start avoiding or dropping their dose, their basophils become more reactive. So this is potential for, real-time monitoring of therapy and trying to make these, long-term maintenance dosing decisions. And then here we also looked at total IgE, peanut-specific IgG4, and specific IgEs for ERA H1, 2, and 3. And those patients who were not successful at that first 3 months time point had unsurprisingly had higher levels of IgE, whereas those that were successful had lower levels of peanut-specific IgE. We looked at 4 to 55-year-olds. Can this be done in toddlers? The IMPACT study published earlier this year answered exactly this question, looking at peanut oral immunotherapy in 1 to 3-year-olds, and showed that this is safe. 71% of patients who were in the peanut oral immunotherapy arm had successful desensitization. They also looked at a 6-month withdrawal period, so a little bit longer than our POISE study, which was 3 months. And they showed that 21% had remission or sustained unresponsiveness after, and were successfully able to pass a 5-gram food challenge even after avoiding for 6 months. The majority of side effects were mild and moderate, so very similar to the older kids and the adults, and that this is safe in young kids, which is really important because we're diagnosing peanut allergy with early introduction quite early now. And what was really interesting in this study is that remission rates showed a trend to be higher in the younger toddlers, in the 1 to 2-year-olds. Here we're looking at peanut oral immunotherapy remission rates of 50% compared to 2 and 3-year-olds, and in the per protocol sample even higher. So these are small numbers, but the trends look really promising. So oral immunotherapy, I've talked about the benefits. The limitations is that it can be slow. There are some side effects, which we've talked about, and it's allergen specific. So if you're multi-allergic, to milk, wheat, egg, peanut, cashew, lots of tree nuts, that this process requires ingesting all of those foods. And we looked at this as an opportunity because food allergy is an IgE-mediated disease. So luckily, we've had anti-IgEs in the pipeline for a long time, and we really were thinking about how can we include that. But before I show that, I wanted to show you the really pioneering work led by Kari Nadeau now a decade ago, looking to see if patients are multi-allergic. The process, 10 years ago was really to desensitize patients to one food, and then the next food, and then the next food sequentially. And I've told you now that the process can be 1 year, 3 years, 5 years. So you take a 3-year-old, and let's say the shortest time period is 1 year, and they have 5 foods. Then we're talking about 5 years of desensitization therapy. So what we did at Stanford is do multi-allergen oral immunotherapy simultaneously. And here I'm showing you our phase 1 study looking at single allergen oral immunotherapy. This was to peanut compared to multi-allergen oral immunotherapy. The time for a 10-fold increase from the original reaction threshold to peanut, and the percent of subjects that reach that dose. So everybody gets to the top dose, 100%, right? But it takes a little bit longer when you're doing multi-allergen oral immunotherapy because the updosing to get to those larger and larger cups of food flour takes a little bit longer. But it is equally as safe. So the reaction rates for single versus multi are similar. So no increased potential for safety events compared to single allergen oral immunotherapy. So how does anti-IgE factor into this? Thanks to Kari, thanks to many others in the field, including Dale Matsu and our colleagues in Boston and New York and across the globe, we took medications, anti-IgE, the most studied has been omalizumab, and has been approved for use, clinical use for asthma and chronic idiopathic urticaria. And we said, let's use this in food allergy. And there have been studies doing this with single allergen. We did it here at Stanford for multi-allergen. And the idea is to use omalizumab as a preconditioning treatment, kind of how you would think about with chemo preconditioning, right? And use it for 8 weeks prior to initiating oral immunotherapy, and then use it as an umbrella. So 8 weeks before you do oral immunotherapy, 8 weeks while you start oral immunotherapy, then stop using omalizumab and continue to increase with the oral immunotherapy foods. In this way, you're able to, we hypothesized, improve the speed, the safety, perhaps the efficacy, and still maintain allergen specificity at the end of the day. And then, so you have a build-up period where you get to a maintenance threshold that you decide in your protocol. That's relevant. That could be 300 milligrams, like one nut, 4,000 milligrams, like one serving size, a slice of toast if it's wheat. And then you could test for sustained unresponsiveness. So our MAPX study is our phase 2 study that we conducted at Stanford, where we used that process with omalizumab compared to placebo omalizumab. Everybody received multi-allergen oral immunotherapy. And at the 36-week time point, 9 months, 83% of those in the omalizumab arm were able to pass a food challenge to 2 grams and 4 grams for 2 or more foods, compared to 33% in placebo. They reached their maintenance doses faster in the omalizumab arm. Side effects were improved, but GI side effects still remained. And 4 grams, to put it in perspective, and this is work that was done with my colleague, Sandra Andorf, 4 grams is a half a glass of milk, right? A slice of wheat toast, a handful of nuts. This is really impactful for our food allergy families. The MTAC study looked at long-term dosing following this combination approach, and really trying to understand sustained unresponsiveness and long-term maintenance dosing. This was done at 7 different sites across the United States. And here we did omalizumab pretreatment, multi-allergen oral immunotherapy introduction for 60 patients, and then desensitization food challenges at week 30. And then at week 30, then patients were randomized to continue on 1,000 milligrams each of their foods, 300 milligrams of each of their foods, or 0. Everybody received food flowers, so people were blinded. And then we did long-term challenges following at 6 weeks, at week 36, to really understand these 3 different dosing regimens. Here I'm showing you in red the 2 groups, the 1,000 milligram maintenance and the 300 milligram maintenance combined, because they were continuing food, compared to gray, which was the blinded discontinuation or avoidance. And at that 36-week time point, 85% of those who continued a maintenance dose for all of their foods were able to pass food challenges to 2 grams for 2 or more foods, compared to 55% who went on to avoidance for 6 weeks. And here you're looking at 3 foods, 4 foods, 5 foods, and 4 grams. And so for us, this was very exciting. And this is, pilot information, looking at only 60 individuals, but really deserves further investigation to understand if this combination approach can actually improve long-term outcomes and sustained unresponsiveness. And so cumulatively, we've looked at a number of people with this combination approach, and we really wanted to understand, what about omalizumab as monotherapy? If patients don't want to continue to eat food or ever ingest the food, how effective could a biologic be in providing safety and changing threshold sensitivity? So I mentioned that we do 8 weeks of pretreatment with omalizumab before we do food. when we introduce food at that 8-week time point, it's a rush immunotherapy protocol. So we actually test people to as high as almost 2,500 milligrams of the food protein combined. So if somebody has 2 foods, then it would roughly be 1,250 milligrams of protein of each of those foods. If somebody had 5, it would roughly be about 500 milligrams of each of those foods. And so looking at this in total, what we see is that 50% of individuals who receive omalizumab for 8 weeks are able to reach the top dose that we tested, and then 50% reach less. And so it is variable. And that leads us to question, why do we see variability of response with omalizumab? And is it because of the dosing that we're using for the omalizumab dosing? We're using asthma-based dosing. Is it the length of time that somebody's getting pre-treated? If we treated for a year, would it be 100% are able to reach the top dose? And in those individuals that aren't, how can we understand the immune mechanisms that lead to this variability and understand best patients for this type of approach? So to answer the question about are we using the right dose of omalizumab, this study gives us a little hint of what's possible. And our MyMax study, which was published earlier this year, led by Tina Cinder in my group and Maria Garcia-Larrett in UCLA in California, looked at 60 individuals, and we looked at alternative dosing of omalizumab, similar to what we use for chronic spontaneous urticaria, where everybody received 3 injections of omalizumab at 0, 4 weeks, and 8 weeks. And they received 150 milligrams of omalizumab at those 3 time points. And then we introduced low-dose multi-allergen oral immunotherapy at 300 milligrams or high-dose multi-allergen oral immunotherapy at 1,200 milligrams, and looked at a very short endpoint of 16 to 18 weeks. And what we saw is that there were no differences in the safety profile between these 2 regimens. So this kind of combination approach was safe. And it led to immunological changes within 18 weeks. And we saw that 70% of all participants showed a change in the IgG4 to IgE ratio, an increase in that ratio, which we think is good with food allergen oral immunotherapy and in any immunotherapy in at least 2 foods. And importantly, these patients were then able to incorporate foods into their diet. And so that had some real world experience there. So what do we know about anti-IgE? It shortens the time to maintenance. AEs are diminished, but they're still persistent, particularly GI side effects. We're not sure about sustained unresponsiveness. The pilot data looks exciting, but larger studies are needed. And we can see that different dosing strategies for anti-IgE can be helpful. But what's the best scenario? What's the best patient characteristic? What's the best pre-treatment with omalizumab duration for maximal benefit? There are, each of these studies brings more questions to the field, which is exciting for future scientists and physicians who are caring for food allergy patients, because there's plenty of opportunity. There are so many unknowns, and we learn more as we do these studies from our patients and from our data. So some of these questions will be answered in the OutMatch study, which is a phase 3 study we're doing through the Consortium for Food Allergy Research, funded by our NIH in the United States. And it's across 10 sites in the US. And we're looking at 225 individuals, studying patients as young as 1 year old up to 55. And we're looking at different durations of omalizumab as monotherapy. So stage 1 is looking at omalizumab monotherapy for 4 months compared to placebo, and then there'll be food challenges. Stage 2 looks at this omalizumab facilitated multi-allergen oral immunotherapy that I've talked about, this combo approach versus omalizumab monotherapy, and the duration of that stage is 1 year. And then really importantly, we felt it was important to include in the study itself an opportunity to do dietary food introduction beyond these treatment paradigms to understand long-term dosing with real foods. And so there are a lot of people involved in this study, a lot of patients, a lot of teams, and very exciting. We're still currently enrolling in this study. There's many other studies going on with omalizumab in food allergy. This is just to highlight a few, so more data to come in coming years. And then I just want to shift gears really quickly and talk about dupilumab, which many of you may know is an anti-IL-4 receptor alpha targeted monoclonal antibody, and has had great success and approval in our asthmatic patients, in our atopic dermatitis patients, in our sinusitis patients. And there's huge interest for this in food allergy as well. The company has done 2 studies looking at dupilumab as monotherapy in peanut allergic individuals, and then also separately in conjunction with oral immunotherapy in peanut allergic individuals. We have 2 studies. So those 2 studies are done enrolling, and we're waiting for the data. We have 2 studies using dupilumab in conjunction with milk allergen oral immunotherapy. And we're really excited about understanding whether it can improve sustained unresponsiveness outcomes, as well as improve on the GI side effect profile. I think you've heard me mention it long enough. This is, the thing that really bothers patients on a daily basis when they're dosing with oral immunotherapy, and it's common. So it's important that we try to address this in our future therapeutic approaches. And then a combination study looking at omalizumab and dupilumab called the Combined study. So this is really to understand if we pre-treat patients with omalizumab and then introduce multi-allergen oral immunotherapy while under the cover of dupilumab, can we have improved long-term outcomes for desensitization and sustained unresponsiveness? And so really, if you think about it, we're using an anti-IgE to kind of soak up all of the free IgE in the patient's system. Then we're looking at dupilumab as a anti-allergic inflammatory modulator, right, to dial down Th2 responses while we ramp up multi-allergen oral immunotherapy. So this study is also currently enrolling, and we're very excited about the future looking at that. And so I think this is one of my last slides. There are many biologics targeting allergic inflammatory cascade. And, we didn't get a chance to really talk about the alarmins, which can really be the first signal to skew towards Th2. And we've certainly talked about IgE. There's many active drugs in investigation, and listed here just for a partial list, including also other improvements for anti-IgE, passive antibody immunotherapy with IgG4 targeting food-specific epitopes potentially. And then any of these biologics could be used as potentially as monotherapy, but also in a combination approach with oral immunotherapy, sublingual immunotherapy, epicutaneous immunotherapy, and modified allergens. So I think, the next 10 years, we will see an explosion of drugs for our food allergic patients, and perhaps combination therapies. And so we really do have to think mindfully about the science that is driving these clinical responses, and understand the success and the failures, to really understand how we can improve for our patients. So in conclusion, I hope I showed you that OIT is efficacious. Durability really requires some regular maintenance therapy. The optimal maintenance dose is probably personal, and can vary across the ages. And we really need biomarkers to help us identify right patient, right time, right approach. Biologics are really exciting, and I think we have to be mindful about the approaches we use with biologics, especially also for healthcare economics. These are not cheap drugs. And it allows us the opportunity to understand mechanisms driving food allergy disease, and an opportunity to really further diagnostic, prognostic markers. And in all of this, long-term data is needed to assess the impact, good and bad, on the patient and the families, the burden of the disease balanced by the burden of therapy. And with that, I'm grateful to you guys for listening to me, and happy to take any questions. Also very grateful. It takes a large team, as you can see, and very grateful for our funding and supporters.
Sharon, thanks a lot for your presentation and interesting data also about the use of biologicals. Before we get into the discussion, I just want to encourage the audience to ask any questions using the FAQ function and the chat function. First of all, we have to get something clear. Of course, peanut butter is available in Germany, not just not a staple as in the US, but it's available and loved by many.
Yeah.
What
do you like it with honey or with jam?
I'm not a
Not at all.
I'm just peanut butter and banana.
Oh, there you go. Yeah.
But let's take a step back. I wanted to ask you something about the use of OIT and omalizumab. That's not a standard of care in the US, right? It's just for study use right now.
Yes. Yes. So that's a very good question. So our phase 2 studies have been published. We published all those protocols. We've been happy to share it with our academic colleagues as well. And some in the US, practice is different probably than Germany. And we have academic practices where we need insurance approval to be able to provide most therapy. So Palforzia, omalizumab is not approved by the FDA or insurance companies for use in this regard. However, there is off-label treatment in the US that's possible. And sometimes you can make appeals to the insurance company in that regard. And then practices have the ability to, use the best evidence that they have to be able to serve their patients. And so some practices are able to use this combination approach because they've trained with us and gone out into practice, or have a large volume of food allergy patients seeking care. So there are centers in the US that do use this approach.
Okay. But it's actually quite the same in Germany. Like, we also can appeal to the insurance company the same way, or use them in studies. Okay.
So while we are looking for other questions from the audience, Sharon, one short question from me. So first of all, impressive. And I think this really, it's not only one step forward, it's multiple steps forward. Congratulations. My question goes to the difference in effectiveness concerning the age. What do you think is behind this? Why is it so different? And could you perhaps comment also on adults? But you did it primarily in children, didn't you?
Yeah. So really great questions. Thank you. And I'm curious what you all think as well. The age, I think, there is some immune plasticity, as we know, in infancy. And, I think that we diagnose food allergy earlier and earlier now. And this may be a real opportunity at the time of diagnosis to really study this, because this trend is really impressive, that perhaps their immune plasticity can be retrained better when they're more malleable in infancy, young toddler ages, compared to later in time. Desensitization can be effective in all ages. We do not see differences in success rates in adults, children, or toddlers. Compliance becomes an issue with regular dosing. There's taste aversion, trauma from previous accidental exposures and allergic reactions that really, the psychology of reactions can really be limiting in treatment options for some individuals. But the immune responses, I think there's an opportunity for perhaps more durable responses where perhaps we don't need long, like years of therapy if we start earlier. And so I think larger studies in infants and young toddlers are important and needed. The first study was done and really is large. The first large study has been done now and shows that this is safe. I think people were scared also, like, how do we do this in babies? But we can do this in babies, and it is safe. And then the Outmatch study is actually studying down to 1. So, food can be safe, and biologics, really the safety of biologics. We know that dupilumab is approved in 6-month-olds for eczema. So we know that that's safe. So I think that there's real opportunity for more permanent immune modulation in that age group that deserves more study.
Thank you, Sharon. Talking about babies, what is actually recommended in the US? You said peanut allergy is common in the US. What do you recommend to babies at risk? Maybe father and mother do have allergies. When should peanut be introduced?
Oh, that's a great question, Julia. So I know that this differs across the world. The LEAP study was amazing in changing our mindset about early introduction. And I think for patients at higher risk, really early introduction in the 4 to 6 month time period is important. And I think there's variability in how many people we reach and send that message to. And there's some fear from the parent side about doing that introduction. So I think as an allergy immunology field, we need to rise to the occasion and try and fill those barriers, because it's a real opportunity for prevention.
Okay, thank you very much. I think we could talk about this for much longer, but you also prepared a case of the day for our audience. So I'm very curious what you prepared, and yeah, here we go.
Yeah, wonderful. So I have two cases. One is a mix and match. So part of this is just recognition and education, right, for colleagues and for families. What are these nuts? And here's the list. I don't know if Google Translator translated these appropriately, but we have peanut into German here. But peanut, pine nut, walnut, cashew, pistachio. Can you tell which nut on the left side is what? So I'll give you a few seconds just to look at it. And then here you go. How many people guessed correctly? So pine nut is, in the US, we use this in pesto quite a bit and in salads. And it's very tiny nut. Pistachio, often is recognizable because it's green, but they are also similar to cashew. So what we found is that when we desensitize patients to cashew, they get some bystander effect for desensitization to pistachio. Walnut is hard, and walnut is even hard when we're telling people how much walnut is equivalent to 300 milligrams, and it has bystander desensitization effects with pecan that also looks similar but is darker in color. This is peanut, and then this is cashew. Okay, so one small case. We have a 5-year-old with peanut, milk, and egg allergy. And what treatment options, in a perfect world where anything goes, what treatment options are possible to improve threshold sensitivity to one or all allergens? You can do A, avoidance, B, peanut oral immunotherapy, C, baked milk challenge, D, baked egg challenge, E, all of the above. I think there's a voting option. Yeah. Do we have the survey results?
We have survey results now. There are 45% for B and 9% for C, another 9% for D, and 36% for E. And no one has chosen A.
Oh, wow. That is a forward-thinking group. And I think that, any of these are possible. And in different places in the US, people might do not only peanut oral immunotherapy, but milk and egg oral immunotherapy in combination or sequentially. But, my personal opinion is that I definitely look at components for peanut, milk, and egg, but I believe that every child deserves a baked milk challenge and a baked egg challenge. And I know that our Canadian colleagues have also introduced ideas for milk ladders and egg ladders, really to go from baked into less cooked foods with different proportions for slow desensitization for these foods as well. So I'm just so excited that there's so much interest in this, and we're learning from each other about how to make this easy, not only for the patient and also the provider. Okay, so continuing on, he starts on peanut oral immunotherapy and develops itchy mouth and occasional abdominal pain within 30 minutes of taking his dose. Is this common? Ooh.
Well, we will again look at the results. 93% said yes, and only 7% said no.
Okay, so this is common. So 99% of patients will experience some side effect with oral immunotherapy. The majority, like 95%, 80 to 95% are mild. And I always advise everybody undergoing oral immunotherapy that they carry their reaction medications at all times. That includes, first and foremost, the epinephrine auto-injector, and then antihistamines as needed. And so what would you advise to do with the dosing for this child who's having side effects? A, do you want to stop dosing? B, you can pre-dose with antihistamines 30 minutes prior to oral immunotherapy. C, you can take a dose with a small meal, so not on an empty stomach. D, you can drink cold water or ice after taking oral immunotherapy. Here you can choose multiple answers.
Survey is now closed and we will have a look at the results. No one said stop dosing. 42% said pre-dose with antihistamines. 45% said take dose with small meal. And only 12% said drink cold water or ice after taking the OIT.
Yeah. So I think many of you are right. I would not stop dosing for this individual. I want to give them as much support as we can to get them through oral immunotherapy, though this is always an option to stop. Pre-dosing with antihistamines, there was a recent Jackie in Practice article looking at the Pisces trial, where antihistamines can reduce abdominal pain and urticarial symptoms related to dosing. So I encourage you guys to take a look. And this is something that we don't necessarily prescribe for everybody, but if somebody has symptoms, then we feel very comfortable doing antihistamines 30 minutes prior to oral immunotherapy. It's important not to take oral immunotherapy on an empty stomach. So definitely small snack, not a full stomach either. So there's it's the Goldilocks of the happy medium. And then ice and cold water can definitely help with the itchy mouth. I don't know that it will do anything for the abdominal pain, except for making sure that people are hydrated, and it's not constipation or anything else like that. And so that's also important. And then anything else to be worried about when you have GI side effects. The answer to that is I just want everybody to be aware of the complication of eosinophilic esophagitis in oral immunotherapy. This is a clinical pathological diagnosis. The true prevalence of EOE with OIT is unknown. We've done some studies with our poised patients where we actually did endoscopies for a subset of the adults before they started and throughout the study. And we see that there is eosinophils present in the GI tract of food allergic patients who are avoiding the food. So I think that this is common things being common. Our allergic patients have multiple allergic disorders. And regardless, we have to be mindful that if somebody has chronic abdominal pain or vomiting or nausea with every single dose, that should trigger in your mind, should we be thinking about EOE? What further steps should we be doing? There's no consensus in the community. This is really important that we really study this carefully and have this in our mind, because as oral immunotherapy becomes more common, we don't want to miss this. And so that's all I have.
Thanks a lot, Sharon, for this really interesting case. We would love to ask you lots of questions, but we know that time's rushing. We always try to include some kind of career guidance for our audience. That's why I want to at least ask you one question, as you're also such a great researcher. As a foreign researcher, when coming to the US, what kind of research are you allowed or expected to do? And what does a day as a researcher in the US look like?
Oh, that's a great question. So our center is always open to collaborating with visiting scholars. As a foreign researcher coming to the US, it's harder as a student, I would say, at least at Stanford. I think each academic community may be different. But at Stanford, we have the ability to invite visiting scholars. And so if they've finished a degree and are not in the process of the degree, that makes it easier. And oftentimes, all visiting scholars are lucky to have funding from their own institution when they come. And what we try and do is they can't do patient care in the US, even if you have your MD, unfortunately, but you can observe clinical trial research participants, And we really like to have them have a project that's their own. We have, great databases. We have databases with colleagues across the country and that we're building on. And so there's so many questions to be answered. There's opportunities to speak with patients, to ask a different type of question, right? Like, how many patients breastfed their babies, and did that have any impact if they were eating peanuts and tree nuts while they were breastfeeding versus not, or skin to skin, or when did you start formula? There's so many questions in our field that remain that are really important and can lead to a great research project for our visiting scholars. And then we share our protocols, and you see how we do it, and you become familiar with the process, the good and the bad, what to be alert and aware of. And we hope that you take these protocols back to your home institution and you grow your food allergy research, and that we continue the collaboration in the future, and we shrink the world in our field. So that's the best scenario. That's the dream.
And that's so nice to hear.
Yeah. Very good. Sorry, Sebastian. Go
No,
on.
I just wanted to say that's so nice to hear. Well, we'll take that as an open invitation.
Yes.
Okay. As we said, time is already moving on. We always try to include some fast questions at the end that are also kind of personal to you, and maybe just try to answer them just straight out of your gut, just in one quick sentence, and we'll get on with that. Julia, do you want to start?
Yes. If you had to choose between research and clinic, what would you choose?
Research.
What is your secret to relax after a long day of work?
Spend time outside with my kids.
If you were a young researcher starting from scratch, what topic in allergology would you start your research?
Food allergy.
Food allergies, are they on rise, or are they under control?
They're on the rise, despite our best attempts at prevention, I think.
Do you have allergies?
No.
Fiction or facts? In your free time, do you prefer reading papers or non-scientific literature?
Both.
Okay, thank you very much for answering these questions. Yeah.
Thank you for the questions. Wow.
Okay, and I think now it's time for Christian to come back to us, because our time is over, and I think you have a meeting in 2 minutes. So thank you very much for being here.
Oh, thank you so much for having me. It's been such a pleasure.
It's been a pleasure having you.
Thanks, Sharon.
It was really a pleasure to having you in this webinar, and auch bei dieser Jubiläumsausgabe, meine Damen und Herren, jetzt auf Deutsch, möchten wir uns wieder ganz herzlich bei Ihnen bedanken für das Engagement, das Sie gezeigt haben bei der Beantwortung unserer Umfragen. Und wir möchten uns heute auch bedanken bei dem Sponsor des heutigen Abends, bei ALK. An dieser Stelle noch einmal der Aufruf: Bitte beteiligen Sie sich an unserer Umfrage, die gleich jetzt nach dem Webinar startet, und sagen Sie uns Ihre Meinung. Und wenn Ihnen dieses Webinar gefallen hat, dann schalten Sie auch gern wieder im November ein, wenn uns Professor Oller zeigen wird, wie die Forschung von heute zur Gesundheit von morgen beiträgt. Und genießen Sie jetzt den Abend, Ihre Zeit bis zum nächsten Webinar, und wir wünschen Ihnen alles, alles Gute. So. Goodbye to everyone.
Goodbye.
Bye.
Bye-bye.